So the some of the issues that we have noticed is, as I mentioned, hyperglycemia in people who have not had diabetes and people presenting with diabetic ketoacidosis. Again, these we try to understand because pancreas doesn't have ACE2 receptors, which are the main ones, which kind of say. So then, whether it is related to interleukin-6 and then the cytokine storm, which creates a higher degree of insulin resistance, so that causes hyperglycemia and then related ketoacidosis state. So what people observe and notice is that to manage this hyperglycemia, people require a higher amount of insulin to manage it. And then there are various protocols written to kind of manage these individuals. So giving variable rate insulin infusions, which at a higher dose and a different protocol compared to what they were used before. So that was one of the early learnings. And the second thing is in people who have got hyperglycemia or towards ketosis or ketoacidosis, they're also severely dehydrated. The initial thought was that the damage that are occurring in the lung was due to an ARDS, acute respiratory distress, and then giving the fluid that are usually given in people with diabetic ketoacidosis, so that can flood their lungs and then kind of worsen their fluid status. And then different protocols were written to give a reduced amount of fluids in people with diabetic ketoacidosis at that point. But and those were swiftly changed to a different model when we learned that the damage that is occurring in the lungs is more of a microcoagulopathy, so which is due to an inflammatory response and not due to fluid. And then the previous fluid protocols were started being used. So having said that, in a hypercoagulability, again, people with diabetes and obesity are got a higher risk of having this hypercoagulable state. And then whether that is adding to the damage and severity in these people. And then what is the right anticoagulation plan that should be used for the subset, or is it COVID as a whole? That became another issue as well. The most number of people that we have seen so with diabetes or people with a background with type 2 diabetes, so we have hardly seen anybody with type 1 diabetes getting admitted due to COVID-related severe complication. And then we have had anecdotal evidence or supporting this, so from other countries in Europe as well. But the overall risk of exposure, say, due to COVID in the diabetes population seems to be similar, so to people who do not have diabetes. So, but the risk of complications seem to be higher in people who have got diabetes, whether it is type 1 diabetes or type 2, so diabetes. And the other issue related to diabetes is that the people who have already got other complications due to diabetes, so it be renal impairment, so in which the fluid management will become an issue. So people who may have an acute foot infection due to a diabetic foot ulcer, and then that itself may make them prone for sepsis, and then how you would use certain medications in this subset of patients. And they may have underlying cardiovascular disease and then a heart failure. And then we know that independently that cardiovascular disease itself is a higher risk for mortality and morbidity in people with COVID. And then how do you manage the fluid and then the overall the medication? And then a certain medication we use for diabetes, like metformin. If people who are at high risk of acute kidney injury, then you won't be able to use them. And similar with the story with SGLT2 inhibitors, which can cause a higher degree of dehydration. And then they were no. And people who were not on insulin, they had to be started early on insulin therapy, and their insulin requirements were much higher. So, and in people who get admitted because of this. And yes, those are some of the issues that we encountered. So in people getting admitted with diabetes. But there was a significant challenge in preventing people developing diabetes-related complication outside the hospital. So because people were redeployed from the diabetes teams, and then so most of the face-to-face consultations that were happening that no longer were happening, people had to swiftly switch to a telephone consultation model. And then while doing this, you were able to give sufficient advice to modifying and asking people to check their glucose more frequently and regularly. But if people needed a new treatment option, and then how to educate them to start this, whether it is glucose monitoring or whether asking them to take insulin and how to initiate new insulins for them. some people try to do video consultation, and some try to do the face-to-face consultation. So with all the safety measures in terms of the masks and hygiene and etc. And those were another challenge. So one, to what to do with people who are in the hospital. So to manage their diabetes safely while they're getting treated in ITU or HDU or on the wards for their COVID-related complications, while minimizing the impact of diabetes to that. And similarly, so how to reduce the exposure and then managing people safely outside the hospital so that